Good afternoon, everyone. We are welcoming all to a very timely important discussion regarding adolescent depression, presenting today by Dr. 𝗦𝗨𝗕𝗦𝗪, Senior Lecturer in Psychiatry, Faculty of Medicine, Colombo, and Honorary Consultant Child and Adolescent Psychiatrist, Lately Hospital for Children. Madam, we are welcoming you warmly to presenting this week.
So, as I have highlighted before, today my presentation will be mainly, targeting the primary care clinicians. And this topic is very timely because of our rising prevalences. And let's try to work through the symptoms and signs of adolescent depression. I think the messages are there saying can't hear. That's all, no? Right. So, we will be looking into the signs and symptoms of depression through the adolescent development, because we all know adolescent development is very challenging and it's a highly complex time period, and there are many developmental periods that are very vulnerable also. So let me take you through this journey of adolescent development first during my first part of the presentation, and my latter part of the presentation we will try to discuss and work out what is normal versus what is abnormal. I think there is a disturbance going on here, right? But despite that, and at the end of the presentation, apart from the identification, I would like to highlight briefly around the principles of management also, because most of the time in the primary care, sometimes we may have to manage some of the patients, but mostly it's about identification. So if we talk about, how do you slide through here? So if I am to sort of rush upon the initial slides that I was already discussing, we talk about adolescent development. So WHO defines adolescence from 10 years to 19 years. And there also, they have sort of categorized this adolescent development to early, mid, late and the teenage years. And each and every, step meets with unique developmental needs. So I will be not rushing upon all these developmental, milestones, but let's see quickly what happens physically. So we all know in adolescent there is a physical development, the pubertal growth spurt is there. Along with the physical development, you have certain hormonal changes. So for example, GnRH and other hormones, they start to sort of increase, and as a result, their sex hormones also increases. Their secondary sexual characteristics start to develop, and there is adrenarche, things like body odor, enhanced muscle mass, and then physical transformation with the growth spurt. Along with that, their fat distribution also changes. And this may be a highly vulnerable period for an adolescent because of these physical changes. Now, supposing, I think most of the time the teenagers are conscious about how they look, how they feel, their bodily changes, their body odor, skin changes like acne. So, these are the sensitive areas that we need to pick up as clinicians who are working with adolescents, and we had to walk through this journey with them to clarify what is normal and what is the not normal thing, as well as we need to work with the parents sort of to enlighten them and support them to navigate through this challenging time period. So description and understanding about the physical development is very, very important. And apart from the physical, along with the physical development, we also know that adolescence is highly vulnerable period in terms of neuronal maturity. Specifically, synaptic pruning and myelination occurs during this time. As you can see, one with the brain maturity, say by the age of 20 years, like it takes some time for the frontal lobe to mature. And especially if we talk about the prefrontal cortex. Now, I think one of the common complaints that the parents and the teachers have is some of the teenagers are very impulsive, aggressive. They may agree to something with you, but when they go out with their friends and when they are with the crowd, they will engage in a totally sort of a spontaneous, difficult, bizarre behaviors. So why this is happening? So because of this. Why? Because their prefrontal cortical maturity is not much developed and their limbic system is also much hyper functioning. So that decision making, impulse regulation is not fully developed during the adolescence. So that is why they are very high, impulsive. They can be moody. So all these things can be explained biologically. And this is a time period where the brain is very much sensitive to stress and other environmental or other vulnerabilities. Why? Because now adolescence is also a time period where brain plasticity occurs. So during this time, children learn a lot of things also. They are very inquisitive, they want to try new things, and the school environment also facilitates these kind of experience. So a lot of skill training, learning, and new skills can be acquired during this time because of this plasticity, as well as they are more susceptible to stress. So that is also something that we need to keep in mind. And they have also found out, certain neuroimaging studies have shown that there is an increased activity in the reward processing pathway, especially when they are with the peers. So this is why they like to seek, sensation seeking activities. When they are very cheerful and happy, they like to go out, they like to seek independence. So all these can be explained through this, physical and neurodevelopmental, brain developmental activities. And apart from the physical and the brain development, there is another element that we need to discuss, that is the cognitive development. So I think sometimes the parents might come and tell me, now you may also have this experience. Now they are a little bit argumentative, not the child who was there. So they may search on certain topics, say they may have these ideological views of self and the world. They may like to debate and explore on certain topics. So abstract thinking, concepts, reasoning, and this decision making and problem solving is the areas which are being developed during this vulnerable period. And cognitive flexibility is also something that they are learning to development. And there is a rapid advancements in memory capacity and processing as well. So they have a lot of room for information, new information to gather during this period, and we can make use of this. And the other part that is essential when we talk about adolescence is their emotional regulation. So this has several aspects. One aspect is the ability to identify, recognize and understand their own emotions as well as the others' emotions. So empathy is something that is being developed. And then the self-awareness is also expanding during these years. So this is very much essential. So emotional coaching and regulation is very much essential and lays foundation in healthy coping strategies. So we talk about coping during adolescence, especially when there is maladaptive coping that can cause serious, problems during the adolescent years. So the other aspect that we are worried about or concerned is the self-awareness. So as adolescents, you have the physical development, your cognitive development, then you have the emotional regulation, and then you have the self-awareness and the self-perception which lays the foundation for their identity. So we talk about identity a lot during the adolescent years. So they may experiment certain roles, align to certain values, explore certain beliefs from time to time. And this behavior may be quite challenging to parents sometimes because they may not necessarily understand the motives behind an adolescent sort of experimenting or experiencing these roles and beliefs. So there may be some challenges in communication. So we need to explain. And a common complaint is that, okay, now he's starting to do this and that, only a few period, and then a little time they are stopping this. They won't continue. So that actually can be explained in the context of their identity development to some extent, right? And also they will understand and try to explore their personal strengths, their weaknesses. So as adults, we need to be very much empathetic and support and mold them towards developing a positive self-worth and a positive self-esteem. Otherwise, there may be problems, in the future. There are certain behavioral and emotional issues which can associate with negative self-esteem and negative self-concept. So, social identity is also a significant component during adolescent years. So, we all know that during this time they like their peer group very much. Sometimes it's very challenging. If the parents tell something, they don't do, but if the peers say something, they will do. So, constant struggles, and there are a lot of influential behaviors that they would want to conform. And there is a very much a biological basis for this also. So, and they seek independence, they seek autonomy during these years. So, one thing we need to be vigilant during this time is, now when we talk about identity, now these days the online activities are also significant. So, apart from their real, identity, there is this online identity that is sometimes shows a contrast from the, real, when you talk to them, they are different, but in the web, they are totally different. So, all these aspects we need to explore with the identity development. And sometimes this seeking autonomy, experimentation with certain, sensation-seeking behaviors, their ways of expressing their identity and their self can cause certain conflicts with authority figures, such as in the school environment or even with parents. So, we need to be very sensitive when we are dealing with this. And now, having talked briefly about adolescent development and major aspects of adolescent development, let's talk about what normal adolescent behaviors are, so-called normal adolescents. So, they can be a bit moody because adolescent mood fluctuates during the day, and they may sleep also a bit later than during their childhood years because there is a lag or delay in the melatonin secretion. So, they may wake up a little bit late than, stay late than their grown-ups or when they were children. So, this may be sometimes a problem for parents, And then they are greatly influenced by peers. They are sometimes preoccupied with their body image, certain sexual behaviors. They are preoccupied with masturbation. So, these kind of, happens during the adolescence. And sometimes they may occasionally experiment certain things like cigarettes or alcohol, These are all out of curiosity and extremely self-involved. And they have a very, esteemed feeling of themselves. So, their self-perception is a little bit, higher. And they have self-conscious. They are very self-conscious about them. So, sometimes with the slightest color change, slightest eruption of acne, they are worried, right? and they actually identify parents' faults also during these times. So parents has to be very patient, and there may be complaints of parental interference. So that is also not uncommon, and there may be certain risk-taking behaviors which is happening. Such as, risk-taking could be two ways. One thing is the healthy kind of, they go into certain sports clubs, hiking, all that. It could be maladaptive, like risky driving, experimenting with drugs, engaging in, multiple relationships which are unhealthy. So all these could be unhelpful risk-taking behaviors which can happen, which is not normal actually. And when we talk about adolescent, the transition matters. So first you have the interactions and the perception with the self, and then it increases and expand towards the parents and the peers, and we need to prepare these adolescents to community, society and globe in large. So multiple interactions. So this is more systems type of a model that I talk about, that they have to undergo, which can be quite confusing. So developmentally, so transition from the peer to the community might be a challenging situation. For example, an O-level student to A-level student, challenging. From A-level to the university transition, again meet with quite a lot of challenges. So we need to understand this developmental transition when we deal with adolescence and correlate that with the certain characteristics of adolescent development, as I discussed earlier, if you are to understand their experience. And briefly about adolescent communication. So first thing is, as clinicians, when we interview adolescents, we need to have this non-judgmental approach. We need to be calm and patient and show unconditional positive regard, right? It's too much to ask from the clinicians, I suppose. Not too much, right? But then again, sometimes the parents may want to be heard as well. So in a session, always give priority to the young person, explore their concerns, validate their experience. At a later stage, you may engage with the parents and sort of explore more, get collateral information. But see and interview the adolescent first, otherwise they will not engage with you. As parents, few helpful tips that you can tell them to sort of, avoid certain conflicts and confrontations is, with adolescents, you need to pick your own battle. You can't pinpoint all the problem behaviors and work with them. You need to be very patient and empower and try to engage the adolescent in the decision making. Give them the, this authority to decide on certain things also within that family. But never sort of, give too much of authority. So there should be a very much of a fine tuning here. And sometimes, they love to be felt important, their feelings validated. They like to talk about what they have learned, about certain topics which are happening, themes which are happening, they have explored during the, their school time, or what's happening around the world. So build up that connection with them and allow them to debate around certain topics with the family. That is very healthy. So what I want to highlight is, adolescents may be a bit moody. They may seek independence. You may feel that there is a bit of disconnection from the family. But majority of the time, they are having a satisfactory connection with the family members. So let's see if it doesn't happen like that. There is a problem. So majority of the time, despite these normal adolescent problem behaviors, adolescents have a satisfactory connection. But what are the instances which things are not normal? So cries for help. One thing is, So if they regularly use alcohol and other drugs as a coping or certain experimentation, regularly using, and there is sexual promiscuity, lying, stealing repeatedly, right? And they may engage in destructive or delinquent behavior. Sometimes you see only the problem behavior. This is like the tip of the iceberg. There may be so many other vulnerabilities or certain problems. There may be other diagnosis which is behind this presentation that we need to be vigilant of. And then there could be isolation, poor academic performance, and persistent negative attitudes towards the self and their surroundings, and frequent temper outbursts. So these things are significant. This is not normal. And to the worst extent, if we talk about self-harm, self-mutilation, suicidal ideation and attempts, now this is not the normal adolescent behaviors. We need to intervene, engage with this young person and see what is actually wrong with this child. So these are the cries for help that we need to be vigilant of. And moving on from, I think we discussed about the development now, we discussed about the so-called, normal adolescent behaviors, then we sort of discussed how the problems present. Now let's try to, look at certain clinical scenarios and see how do we detect depression in adolescence, because one of the challenging things that is we are dealing with is that we don't see the depressed mood in adolescence and you may miss it. So how are we going to deal with this? So in here there is a 12-year-old boy presenting with somatic symptoms and school refusal behavior for some months, and you see there is irritability, persistent irritability, and there is a drop in school performance, and whenever you ask the child to study, he will have a bit of tantrums and anger displays towards the parents, and he was withdrawn most of the day and described feeling tired, fatigued easily. And the other thing is the concentration difficulties and finding it difficult to fall asleep. And he also reported feeling lonely. Now look at those symptoms. So I want you to keep this in mind and move on to this 15-year-old girl presenting with chest pain and faintishness. So more anxiety symptoms, specifically near exams. And this is actually sort of associated or accompanied by some of the mood changes, felt irritable with peers and teachers, and she also had excessive sleepiness and reduced eating. So here the picture is more mixed anxiety and depressive type. But they hardly came with depressed mood, they came with irritability and other presentations such as disruption to biological symptoms. And then if you go to case 3, this is another end, a spectrum. So they present in various ways. So 12-year-old girl with low mood, lack of interest and excessive sleep for 1 year duration. So this is a very early onset and clearly not the normal adolescent behavior. And she had passive suicidal ideation. There's a very strong family history of bipolar disorder. And also she heard certain voices. So some psychotic-like behaviors have also emerged recently in this presentation. So this is more of a psychotic type of a depression with suicidal ideation, which is more severe type of a depression. You see different clinical presentation. I mean, these are the 3, but I can go on like multiple occasions. We see so many diverse presentations. But for your, input, I thought of highlighting only 3 that we have come across in our clinical setting. So having going through those 3 clinical scenarios, if we talk about adolescent depression, what does the global statistics say about it? So the WHO explains that 1 in 7 has some sort of a mental health issue when it comes to adolescents, and 1 in 5 is presented with depressive symptoms. And suicide is a leading cause of disability and death among 15 to 29 age group. So this is no joke. And do all of these children and adolescents come to health sector? No. And if we talk about Sri Lanka, our studies also shows higher prevalence. Now we had the global school health survey. There also we found a significant number of adolescents reporting depressive symptoms and anxiety symptoms. They had bullying, they felt lonely, and some reported that they found it difficult to find close friends during the school. And I think we need a comprehensive, surveillance and screening, to detect these children who are vulnerable, and there is a gap there. And when we diagnose, we know that, according to ICD-11 or DSM criteria, major depressive disorder, for you need to have depressed mood. It could be depressed or irritable mood in adolescents, and loss of interest and lack of pressure for 2 weeks. But this may not be apparent in adolescents. As you may have gone through the previous 3 cases, they presented with different somatic symptoms, anxiety symptoms, school refusal, things like that. Some come with defiance, aggression, right? And then at least, so apart from the 3 major criteria, at least 4 of the symptoms during, out of these, 7 criteria has to be there. So the sleep can be excessive sleep or lack of sleep. Weight also, there could be loss of weight or excessive weight gain. And then agitation, feeling of worthlessness, diminished ability to concentrate. Now, I think in case 2, that was the case. The child found very difficult to concentrate to schoolwork. Actually, that kind of worsened the scenario. And because she had exam anxiety, on top of that she was having anxiety and depression, and that kind of prevented her from engaging in studies, and that kind of becomes a vicious cycle. And other component is recurrent thoughts of death or suicidal thoughts. So out of this, if you have at least 4 criteria, that's major depressive disorder. So what is persistent depressive disorder? So this is a chronic form of depression that is characterized by low mood, lack of self-esteem, social withdrawal for almost a year. And 2 of the following criteria has to be there. So insomnia or hypersomnia, fatigue, agitation or fatigue, low self-esteem, poor concentration, feeling of hopelessness. So this is the other end, more chronic type of a depression. And how does the adolescent depression present? Usually atypical. So you went through the normal diagnostic criteria, but how are you going to look for adolescent symptoms in an adolescent to sort of fulfill this criteria? You may not get it directly. So you need to ask, because if you ask the adolescents, how are you feeling? They say, I'm okay. The mood is also not that prominent, but go through these aspects. Irritability, rejection sensitivity. When they are depressed, they would say their parents don't love them. I am not understood by them. They don't understand me. My school friends hate me. My teachers hate me. So this is the rejection sensitivity that we are talking about. And they have somatic symptoms, very little, distress tolerance and temper tantrums, somatic symptoms. And then there is social withdrawal and they may find it difficult to verbalize the feelings of depression. Instead, they will be very irritable and withdrawn. So this is how you detect, and sometimes they will have certain, I have highlighted, cries for help. All these can be a presenting symptom of depressive disorder. So when we talk about the risk factors for depression, there is a recent Delphi study which has highlighted that when we take a history or something, we can look for this. So there are highly specific and highly feasible to measure risk factors versus, modestly specific and modestly feasible to measure. So let's go through these risk factors and see which are actually common. So biologically, if there's a family history, like in our third case, there was a very strong history of mood disorder. So if there's a family history, that's a clue. And female gender after puberty. And if there's a medical disorder, we need to be vigilant whether they are having depressive symptoms. And the other features like domestic violence, specifically in the Sri Lankan context, high academic pressure, bullying, loneliness, persistent negative self-worth or self-esteem, trauma, substance use, bereavement. These are the other risk factors for a teenager to develop depression. And if we talk about, symptom-wise, you can screen these symptoms. Are there any mood changes? Has the child given up on previously pleasurable activities like sports, engaging with friends, exploring their hobbies, deterioration in academics, and very irritable or anxious mood, social isolation, and suicidality, sleep changes. Go through the biological symptoms and then you will get a clue as to whether they are dealing with a mood disorder like depression. And when we screen, the best place to screen is the school, if you are thinking of a nationwide screening. So when we are assessing, so we have identified the symptoms, now we know. Then we talk about risk factors. So if these are there, we need to get these things in the history. So in the assessments, multiple informants we need to intervene. First the young person and then gather as much as collateral information. Why? Because we need to elaborate and explore the symptoms, the risks associated with the mood disorder and the comorbidities. So that will aid us to refine our diagnosis or differential diagnosis, and most of all understand this adolescent within this family or social context. That's very, very important when we manage a teenager with depression. And you do a detailed risk assessment and you need to highlight the developmental vulnerabilities. Sometimes depression may be a presenting feature, but the comorbidity underlying another diagnosis like ADD, attention deficit disorder, or anxiety or conduct disorder may be there, which we are missing. And we need to explore in detail about the school life, their friendships, their relationship with peers, their relationship with the teachers, their temperament. What sort of an adolescent is this? Is he very anxious, shy, perfectionist child, or on the go, happy child, or irritable, sparky, always arguing? So what sort of a person is this child? Temperamental vulnerabilities we need to explore. And the parenting. So we all know that authoritarian or permissive or uninvolved type of parenting styles are associated with emotional and behavioral symptoms in children and adolescents at later years. So we need to explore these aspects. And other psychosocial risk factors I have highlighted in the risk factor section, and the support system. And what is this child's view of himself or herself and his view of the world around him? What are their goals, ambitions, hobbies? So adolescent crisis, adolescent identity, all these things you need to highlight and assess when you are dealing with an adolescent. So this takes time. If at once, if it is difficult, take multiple assessments. That's okay. Buy time. And in the mental state examination, you need to look for these symptoms, specifically the irritable mood or anxious mood, psychomotor retardation, less reactivity, suicidal ideation and plans, and self-harm. If it is there, it's very significant. Pessimistic thoughts, hopelessness, helplessness, and sometimes there may be psychotic features. So if these symptoms are there, please, now if there is suicidal ideation, self-harm ideation, psychotic symptoms, very severe depression, identify, refer to the nearest mental health clinic. And one other way in a quick clinic setup or at schools that we can screen is using a validated tool. So patient health questionnaire or PHQ-9 is a validated tool to Sri Lankan setting. It is validated to Sinhala and Tamil. So these are the questions that it has, only 9 stems, and you can rate it. Not a very complex one. You can use it, especially in the schools if you are screening, right? And there is a recent app which was developed by the ministry and college also called Nirogi. I think that also has used PHQ-9 for screening, and if there are mild to moderate to severe, depending on the score, you can score it, and if it is significant, you can refer, just for you to know. And then we need to discuss about the differential diagnosis. So the first thing is, we need to tease out whether this is normal or abnormal. So that's why I highlighted a lot on normal adolescent development and the presentations, and whether the child is depressed, and then whether there is a comorbidity, or with this depression, whether there is a risk of bipolarity, whether it is the first presentation of a bipolar disorder. So, and whether there are any other medical causes we need to exclude. And there may be comorbidities like conduct disorder, anxiety, and certain eating disorders, body image problems we need to exclude. That you have to do in your history. Now, briefly around the treatment. So, if you are working in a periphery and you are the only medical officer of mental health or MOH there, or the OPD doctor there, a teenager coming with moderate depressive symptoms or anxiety symptoms near the exams, if you refer them to another service, they may not necessarily go. But sometimes if there is minimal risk, no suicidal ideation or self-harm, and you are confident that there is a depression going on, you may start antidepressant at one point and then refer, right? But then again, you should know, aware of the management strategies. So actually treatment has 3 phases. So there is an acute phase up to 6 to 8 weeks, and a continuation phase, and the maintenance phase. So maintenance phase, depending on the severity and the presenting symptoms and the past episodes, we may continue more than 6 to 9 months. It's very individual. But then again, the principles of management, so this is taken from NICE. If it is mild depression in a child less than 12 years, they give priority to behavior interventions, CBT type of an intervention, but this may not be practical in a primary care setting. So sometimes moderate to severe or even mild to moderate, you may have to go for an antidepressant like sertraline, a very low dose, or fluoxetine, low doses. But always, if you are working in a tertiary care setup, a mental health clinic, try to engage with the adolescent or the child and explore the child's, try to do a bit of behavior interventions, enhance the coping strategies. You can talk to the family, enhance the interpersonal communication. So these are the things that you can do. And then in moderate to severe depression in adolescents, we would go for pharmacotherapy. So I think the current evidence is for like SSRIs like fluoxetine, escitalopram, sertraline, right? And in resistant cases, we may have to use something like venlafaxine. But, again, we need to prioritize with pharmacotherapy, cognitive behavior therapy or family therapy. Sometimes certain, complex dynamics may need certain other intensive, therapy approaches, right? And if the depression is unresponsive to treatment, we may need to reformulate, sort of go through the problems, check whether the diagnosis is correct or whether this is leading to a bipolar depression or any other vulnerabilities, like there are ongoing family stresses, ongoing, stresses at school. Just because you are giving an antidepressant, it is less likely to improve. So we need to look into these factors and intervene in a more systemic manner to improve the mood. Other important thing is, when you treat the depression with an antidepressant or psychotherapy, the depressed mood may sort of, it will come down. They will be reactive. But then the impulsivity might go up. So that also is something that you need to remember. So in child and adolescent psychiatry, we treat the symptoms, not the, presentation. So you look for these symptoms and you need to manage this impulsivity as well when you treat the depression. Otherwise, they are more impulsive and there may be certain risk-taking behaviors which are happening during the adolescents who are depressed. And briefly going through these steps of management, let me highlight this case that we have discussed, the case 2. Now this girl, a 15-year-old girl, presented with chest pain and faintishness, especially near the exams, and she has given up on extracurricular activities, irritable, rejecting peers, excessive sleepiness, reduced eating. So all those biological symptoms are there and the mood symptoms are there, and anhedonia, lack of pleasure, all are there. So she is actually depressed and there is a bit of an anxiety element also. And during the depression, it's not uncommon for teenagers to excessively engage in screens, mobile phones. So she has that problem as well. So this is a sort of a mild presentation that you will see, a common presentation that you will see in the primary care setting. So what are we going to consider in this patient? So I have highlighted certain management aspects that you can do then and there. One thing is managing the depression and anxiety. For that you may go for pharmacotherapy, right? And help with certain anxiety management techniques, simple relaxation check techniques, expressing emotions, identifying difficult emotions which are going along with this, and practically giving and empowering with helping with, managing academic stress, certain study techniques. So these are the things that you can help the child. And then when they are anxious and depressed, they have, given up on previous routines and activities. So you need to restart these routines and then enhance the coping and resilience as overall. So these are the aspects that we are going to talk about when we are managing this child. And one of the other important arms is, with all of these steps, you need to, involve the parents also, walk through this journey with them and empower them to communicate and understand what the adolescent is going through. So specifically, when we talk about anxiety management, so sometimes we may have to use certain strategies like, labeling your thoughts, journaling, and certain, you can do certain times and, set a time and then discuss these worries and sort of go back and sort of train the adolescent to highlight the stressors in which times they are getting anxious. So for example, this child, Near the exam, she gets anxious. So, what are the specific situations near the exam? Sometimes if it's a maths paper, she may get anxious. Sinhala, okay. So, likewise, the triggers, identification of triggers are very, very important. And we also need to have a flexible sleep routine, engage them with certain exercises or extracurricular activities, along with enhancing coping at difficult times. So, this is just a snapshot of what you can do at the primary care as well as in any clinical setup. And quickly, tips for managing screen time. So, we need to balance screens with other activities. We need to keep the meals to promote the family bond, not to use screens. And also, we should avoid using screens as a reward or punishment. And sometimes we may need to have family rules, as during these times you need to keep the devices away, and teenagers cannot use the devices by themselves locked inside a room. They should be kept in a public place. And sometimes they watch these unnecessary videos also, but use the screens to human connection. That is also in a balanced way. So, quickly giving certain tips around that, I will conclude my presentation. So, these are the references. So, some references are global, some are local. So, thank you very much for your time and being patient with today's session. There were technical difficulties, but I hope that it was useful to you all. I am happy to entertain any questions if there are.
Thank you very much, ma'am. Sincerely, I'm apologizing on behalf of my media team for the technical issues that have happened earlier, as well as from our audience. So I think this is a very timely, important topic and very interesting lecture that today we have participated. So, madam, again, thank you so much for joining with us. So, thank you very much.